So, good evening, everyone. So, this is a initiative by Wincars for the e-class teaching for the residents and the fellows who are going to appear for the exam. And this, we are very fortunate enough to have senior faculty and senior professors to give you your tips and tricks to how to approach the case in your examinations and what are the things which you have to look after. This is a second class which you are planning in this year. So this time it's a case of a stenotic lesion. And as an examiner, we have with Professor Jyotsna Madhuri Madam. She is retired professor and HOD from NIMS. And Professor Sunita Vishwanathan ma'am, she is also professor and a retired HOD from Government Medical College, Tiruvananthapuram, and very dynamic, our head of the department, Professor Adit Kapoor, sir. So all the they will be exams looking after your case and giving the tips and tricks. So the format will be for first we will have case presentation from Dr. Amit Jaiswal and Dr. Sumang Mohan from our institute, and they will present the case. After the history, the examiners will ask the tips and tricks. What are the different questions which can be asked, and followed by examination part, and in the final with the DD. The next 15 minutes, we will have words of wisdom from Professor Ajit Kapoor sir, that what are the tips and tricks for how to approach these stenotic lesions in cases of examination. And there are about, I will request the other fellows, or if there are any questions, they can mention in the chat box. We will try that our examiners and we will try to answer most of the queries. And if you are not able to answer the queries, we will have formed a separate group in which we can respond to your queries. Dr. Usha, you want to say something so that we can start ahead with the session?
Yeah, I think good evening, everyone. I think we have a significant number of students. It's quite heartening to see, and they're all on time. So let's go ahead with the case presentation, followed by discussion, Dr. Rupali. I think that's the most interesting part. Yeah.
Yeah. So Dr. Suman and Dr. Amit, you can go ahead with your presentation.
Good evening, respected teachers. I'm presenting a case of a 42-year-old female patient. She was Hindu by religion. She was housewife and she resides in Lucknow, Uttar Pradesh. She presented to us with chief complaints of breathlessness on exertion since 6 years, and palpitations since 5 years, and chest pain on exertion since 2 years. Coming to a history of presenting illness, patient was relatively asymptomatic before 6 years when she developed the breathlessness on exertion, which was insidious in onset and gradual progressive. Initially, it was on walking uphill, climbing 2 flights of stairs, so history of NYHA class 2 symptoms, which gradually progressed in last 1 year to breathlessness on household activities like taking bath, dressing, undressing, and climbing 1 flight of the stair, history of NYHA 3 symptoms. It was relieved by taking rest, and it was not associated with cough expectoration, and it was not associated with seasonal variation. There was also a history of nocturnal episodes of breathlessness around 2 hours after going to sleep, for which patient had to rush to window, gasping for air, with breathlessness that would relieve in 15-20 minutes after assuming upright posture. And there was no history suggestive of orthopnea. She also developed palpitations since 5 years, which was rapid in onset and offset, which was initially episodic, lasting for 15 to 20 minutes, but later on it became a continuous type, which was rapid and irregular as described by the patient, and it was not associated with the loss of consciousness and chest pain. She also complained chest pain on exertion for last 2 years, which was retrosternal heaviness, constricting in nature. It was radiating to left arm and left forearm, and which was not localized to any intercostal space, and it was precipitated by exertion and relieved by taking rest. It was not associated with any nausea, vomiting, and diaphoresis. There was no history of resting chest pain. There was no history of hoarseness of voice and difficulty in swallowing. No history of prolonged fever, joint pain, and skin lesions. And there was no history of limb weakness, altered sensorium, and slurring of speech. There was also no history of any bladder edema, abdominal distension, nausea, vomiting, and anorexia. And coming to the past history, patient is a known case of valvular heart disease for which she underwent some percutaneous procedure in 2005. She was asymptomatic since then. Thereafter, she was advised to take some oral medication and injectable medication every 4 weeks. So coming to the summary, she was a 42-year female patient with insidious onset dyspnea for 6 years. Initially in NYC class 2 symptoms. For last 1 year, she is in NYC class 3 symptoms with history of PND, with history of palpitation since 5 years and angina on exertion class 2 symptoms since 2 years. With also history of some percutaneous procedure being done in 2005 and injectable penicillin prophylaxis. Coming to the differential diagnosis, my first differential diagnosis would be rheumatic heart disease with left-sided stenotic lesion.
I think, Amit, we can just, DD, we can come later. First, we can just have a discussion on the history part. What are the symptoms? Josa madam, Chinta madam, you can go ahead.
Yeah, with this history, you are concluded very well that it is a suggestive of the PND episodes and exertional angina on exertion, but you are not qualified with the palpitation, which you think it, because you said that is episodic, not exertional related. So what do you think the cause for the palpitation?
This is probably arrhythmic palpitation.
Arrhythmic palpitation. So what is the other history to distinguish for the other causes of the PND you would have been mentioned? And for arrhythmic episode of the palpitation, what is the other history you wanted to take it? These two are missing in the history taking.
In arrhythmic palpitation, we can differentiate arrhythmic palpitation as compared to volume overload pattern. There is no history of thumping sensation. In volume overload pattern, tachycardia is usually gradual onset and gradual offset.
The major thing what you wanted to distinguish is arrhythmic for the regurgitant lesion. That's what
Yes,
our main aim. So the regurgitant palpitations are usually may be precipitated with an exertion, or they can be present at the rest. And some of the palpitations which can occur at the rest, especially the nocturnal, is associated with an AR. So those descriptions are the required to distinguish from the other types. To say it is an arrhythmic, as you said it, like associated other symptoms, like the patient has a syncope or presyncope or the CNS manifestations, or even sometimes the loss of consciousness, very occasionally, very rarely that can happen in these patients, and along with the excessive urination, micturition and everything, which do you think that is very so specific for the atrial arrhythmias, or it can happen in any other arrhythmias also?
Those palpitation diuresis in loss of consciousness is can occur in both ventricular.
Post palpitation diuresis we are talking. So because so specifically you are mentioning, I thought you have some arrhythmias in your mind to talk about it. That's what I thought you are going to answer it. This is
Post palpitation diuresis usually occurs.
What is the mechanism? Is because the atrial stretch would produces an ANP, and that is responsible for the diuresis. Anything which can produce an atrial stretch can happen it. So some people will say that atrial fibrillation, and especially going into the flutter, who doesn't have the regular contraction of the atria. So atrial stretch is less likely to then happen. So it doesn't happen in those conditions, but all these things are the relative than a complete problem. So what do you think with these major symptoms of class 2 progress to class 3 with the previous some intervention and history of the PND, palpitations which are arrhythmic origin? And another thing you have forgotten is palpitation. You said arrhythmic, whether the associated symptoms are increased or not. That is also very important to mention. And angina on exertion. So what is the likely possibility you consider?
Likely, ma'am, left-sided stenotic lesion involving the mitral wall and also probably mitral and aortic wall.
Dr. Aditya Kapoor sir will further ask about how do we split the diagnosis in this?
Yeah. So I think, am I audible, ma'am?
Yes, sir.
But my video is not getting switched on, but okay, that's not. So,
Sir, I'm just into it.
koi baat nahi. So, by the history of PND orthopnea, you localized as mitral valve disease, right?
Yes,
And you said arrhythmic palpitations. Madam told you those important points on about the arrhythmic thing. So what do you think is the arrhythmia? What type of arrhythmia is happening?
Probably atrial fibrillation.
Okay. And how do you explain this angina of exertion for class 2 years, history of some percutaneous procedures? Because I think I mistakenly got logged out. So, madam, you haven't discussed these 2 points, I hope.
Yes, sir. I have not talked.
Okay. So, जो मैडम पूछ रहे थे अभी कि we want to split the diagnosis, तो आगे कैसे बढ़ोगे? Angina on exertion, and you say there is some procedure being done in 2005. तो तुम्हारा उसका what is your thinking behind it?
It can be sir, BMV or AVBD, which was done in 2005.
First of all, angina on exertion you think is due to aortic valve disease.
Yes, sir.
Number one. Then you say some procedure was done in 2005. So that
Yes, sir.
procedure was done in 19 years ago.
Yes, sir.
Angina of effort तो अभी आया है. So why do you
Yes,
say
yes.
AVBD? Why do you say AVBD done in 2005?
It's mainly
2005 is what age was she at that time?
from 20 to 21 years, 23-year-olds.
Why do you say AVBD done? You said AVBD, na? If I heard correctly.
Yes, yes.
उस समय तो aortic valve के कोई symptom थे?
Yes. No, sir.
What is the likelihood?
Likely, sir, it was BMV.
BMV. Okay. So some BMV was done, and now she has got aortic valve disease. Hmm?
Yes, sir.
Percutaneous procedure done through radial route, femoral route.
So while right going, sir, from.
तो वो बताना चाहिए ना तुम्हें.
Yes.
So what procedures can be done through the femoral route? इसी case में we
Yes.
forget about the age. She is not 22, maybe she is 50. Quickly just tell us, because you know the exam is, जैसे मैडम अभी पूछ रहे थे कि it is just your approach. Supposing she is 50 years old and she gives you a history of some procedure having been done, same history, right?
Apart BMV, sir.
Same history, 55-year-old dyspnea and angina since last 3 years. Some percutaneous procedure done 1 year ago.
Sir, can be BMV, can be, sir, TAVI.
TAVI.
Amit, what's the age?
Age is 52. Sorry, sir.
अरे मान लो 50
Can be,
years
sir.
है.
Yes,
अगर 50 years की एज है, जैसे मैडम रूपाली ने भी बोला, अगर 22 है तो टावी तो नहीं सोचोगे. टावी कहाँ से आ? 55 years की एज है, she is having some, she had some PND, she had some angina, now some procedure was done. कॉर्नरी नहीं एंजियोग्राम हो सकता. कॉर्नरी एंजियोग्राम भी तो हो सकता है ना. She was 50 years of age, right? So most likely from your history, your summarization is mitral valve disease along with aortic valve disease now, and some possible BMV mitral valve balloon dilatation done maybe 20 years ago. है ना?
Is it possible that still that same mitral stenosis is producing an angina? Is that possible?
I think that's a great question. बताओ.
Yes, sir. Severe MS mitral stenosis can cause angina because of dilated main pulmonary artery can compress the left main coronary artery, and maybe because of severe pulmonary artery hypertension causes RV ischemia, can cause chest pain.
Yeah, the first thing you should talk about the RV ischemia and pulmonary artery dilatation compressing the left atrium. LMCA is commonly reported in the ASD where the gross dilatations are known to occur to have the compression symptoms. So, okay, it is known to happen in the other things also, like a pulmonary embolism, because it is known to be associated with an atrial fibrillation. So they can have the embolism to the coronary, like a pulmonary embolism, coronary embolism. So these are the few of the conditions which can. But all those things doesn't have an exertional anginas. Like embolism will have the patient have an acute episode, but doesn't have an exertional angina. Exertional angina in a PAH because of the right ventricular ischemia, yes, possible. But if that is then responsible, then whole of the history having an exaggeration now is less likely. The patient is having the remitral stenosis without the aortic involvement is also the one other possibility which you have to consider. And the second possibility is associated with other aortic valve diseases. Sunita madam wants to add anything on the history time.
Sunita madam lost the connection, man. We are just calling her.
Sir, can we proceed with the examination, sir?
Yes, yes, ma'am. I am so glad you brought in that angina point because I hope जो भी students सुन रहे हैं, they should be very aware कि angina is a very important symptom of severe PH.
Ma'am, there is a question, sir and ma'am. So there is a question we can have a discussion. Like there, one person has asked, isolated AS due to rheumatic heart disease is rare. It is mostly associated with MS. So I think we had a discussion also in this. And one question is there any fixed criteria for flight of stairs?
Yeah, actually, we are not saying that is an isolated AS. Our point of discussion is the previous in MS, and now is the angina is because of the AS. So isolated AS, the incidence is quite rare in the rheumatic, and we never took that as one of the possibilities. SARS person of the 55 years is related to the HOCM is another condition. Coronary artery disease is one condition which has to be considered. And is there any fixed criteria for a flight of the stairs? Of course.
Actually, yeah, sorry,
Yes.
ma'am. Sorry,
Please,
sir.
please, sir.
No, no, please.
Yeah, the NIHA functional class, which is considered as a standard, it definitely is given the criteria to say that how many flights you are the walking. So there is a definite definitions are there for that.
And if I remember correctly, just adding to what madam says, there are various definitions as madam said, but by and large, अगर exam में तुमसे पूछा जाए, so the definition says it is 12 to 16 or 12 to 15 or 13 to 16, and the standard height is around 8.5 to 10 or 11 feet. So there are various definitions, but by and large, it is 12 to 15, 13 to 16. Somebody says, so that is what it is. Yeah, ma'am. Can we go ahead, Rupali, ma'am?
Yeah, how to differentiate volume overload is already discussed. Right side lesion, left side lesion, the classical sign of the left side lesion is the PND. And whereas the right side is the edema, predominantly the pedal edema, ascites, and as well as the facial edemas. So that is the gradually progresses more proximally. Yeah, we can go for the examination.
On examination, the patient is conscious, oriented to time, place, and person, lying comfortably in bed, and has an average build with a BMI of 20. Patient has a pulse rate of 76 beats per minute, which is irregularly irregular, with low volume and no specific character. All peripheral pulses are palpable, and there is no radioradial radiofemoral delay. Vessel wall quality is normal. Blood pressure is 100 by 70 millimeter of mercury in right arm in supine position. Respiratory rate is 14 cycles per minute with abdominothoracic pattern. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. JVP is 5 centimeter from sternal angle with CV wave with absent A wave. Coming to cardiovascular examination, on inspection, apical impulse is localized in left fifth intercostal space, medial to mid-clavicular line. No visible scar marks or veins, and there are no other visible pulsations. On palpation, apical impulse is localized in left fifth intercostal space, just medial to mid-clavicular line over a single intercostal space and is tapping in nature. P2 is palpable in left second intercostal space. There is grade 3 left parasternal heave along with RV type epigastric pulsations. There is no other thrill or pulsation. On percussion, left second intercostal space is dull, right heart border is substernal, and left heart border corresponds to apex. On auscultation, S1 is variable, P2 is loud with narrow S2 split. There is no S3 or S4, and there is no opening snap or any additional sound. Coming to murmurs, there is a grade 3/4 long diastolic rumble having decrescendo morphology. and is low pitched and is best heard with the bell of stethoscope with patient in left lateral decubitus position. There is also a grade 3/6 pansystolic murmur in left parasternal region that increases with inspiration. And there is a grade 2/6 mid-systolic harsh crescendo-decrescendo murmur at base, which is mixed in frequency and best heard with diaphragm of stethoscope in right second intercostal space, with patient sitting upright and leaning forward. Rest of the systemic examination is within normal limits.
Can you go back one slide? One slide. Just one small thing before Madam asks something. You don't. Why do you want to write S4? Atrial fibrillation में है ना?
Yes.
S4 तो होने का उसको chance ही नहीं है. So why?
Yes.
This murmur again, मेरा कुछ connection का issue था. Did you speak about the peaking and the length, etc.?
Diastolic rumble is long with decrescendo morphology, and the systolic murmur is mid-systolic murmur with the crescendo decrescendo short murmur.
Short.
Yes, mid-systolic.
Sorry, ma'am. Please.
Grade 2.
Ma'am, please.
I think Ma'am Sunita Madam also joined. We can include her also.
Madam could see the slides, or Madam wants to see the presentation once.
My query, ma'am.
Yeah, just
Sunita Madam?
clinical examination first slide. We will talk about what you missed in telling the information, so that Madam also can see those slides. So here you said that there is an irregular pulse. What else you should have been mentioned about it?
Pulse deficit.
That is a mandatory to distinguish from there's an atrial fibrillation to the other types of the frequent ventricular arrhythmia. That is a mandatory. So where you will have, where there is an AF will be there without a pulse deficit. There is a AF, but there is no pulse deficit. And the pulse deficit is less than 10. So what is the condition? When the rate is very much controlled, like the patient is on the digitalis for the control of it, so the rate comes down significantly, so that you don't have the deficit of the 10 beats. So Madam is asking something. Madam, Sunita Madam, please.
Ma'am, please unmute yourself. Ma'am, you're on mute.
Yeah, I've unmuted. Is it unmuted? Can you hear me?
Yes,
Yeah, we
madam.
can hear you, ma'am.
Audible now?
Yeah,
Yes,
you're
ma'am.
audible,
We are
madam.
audible.
Audible. You can ask the question, madam.
Ma'am, again you have to unmute, ma'am. It's still muted.
Before madam comes, the other thing is
now it's
JVP.
unmuted,
You said,
Okay.
you said JVP. A wave is absent because of your suspecting atrial fibrillation. That is okay. C
Yeah,
wave
that's okay.
doesn't give the information to you. Which wave is prominent? You have to say, especially when you have the parasternal pulsations are very prominent with a parasternal heave of 3/3. So what is the abnormality you wanted to say on the JVP? These things has to be pay attention for you to say the severity.
See, and you should also say how is the Y descent, whether it is slow or rapid Y descent. Okay, about the JVP, there is one thing. And second, about the pulse, you have to say all the peripheral pulses, because mitral stenosis is one condition where you can have emboli being thrown into the peripheral vessels. So many times we see them coming with limb ischemia and all. All peripheral pulses have to be examined. The volume of the pulse is important, the character of the pulse. So what is the typical pulse in mitral stenosis, in an isolated mitral stenosis? Aditya? What is the pulse in mitral stenosis like character?
Amit, what's the pulse? Sumam, you were saying something.
You said irregularly irregular. That is acceptable. That is about the regularity. Now the character of the pulse. Is it low volume? The volume you have not mentioned.
It
What's
can
the
be
volume and
low
character?
volume or normal. Usually low volume if there is severe
What do you
MS.
think in this particular patient? In this particular patient,
There is regular pulse with low volume and no specific character.
you have not mentioned. See, you are writing all your findings. You have to write everything. Okay. Whether the volume is okay, and what is the whether, because you are bringing in two lesions. So whether it is a pulses at tardus, so whether it is a slow rising pulse as well, because I think you're talking about angina on effort class 2, and madam asked you a question as to what would be the genesis of that angina. It can be, if you want to associate only with mitral stenosis, it can be pulmonary hypertension, RVH strain pattern producing RVH, which can produce angina, or it can be an emboli which went into the coronary artery, or third is it can be let us say aortic stenosis, which has developed during this time and which has produced effort angina, isn't it? And sometimes severe pulmonary hypertension per se can produce angina. So these are the things that you have in mind. So I think the pulse examination should be a little more proper. Okay. I think all the 5 points in the pulse have to be mentioned. I hope I am clear about that. So next time when you present that way, right? Okay. So we presume that all the peripheral pulses are felt, and it is a normal volume or a low volume pulse?
Low volume pulse.
Low volume. Okay, so please
Low
bring
volume.
in. Okay. And then you have put pickle last. What is pickle? Something got pickled. Huh? The patient is pickled.
Pallar icterus sinuses. There is no
That should come
pallar.
before your cardiovascular examination. Okay. Or your JVP should be part of the cardiovascular examination. Pulse and BP is okay, but the JVP is part of cardiovascular examination. It should come in examination of the CVS. Okay. So you can
Yes,
split it into general examination and cardiovascular examination. The general examination, what else did you look for in general examination? You have said JVP. Did you talk about peripheral edema?
There is
Period
no
edema? Was it
There is
there?
no.
Did you look at it? Was it there?
There is no edema.
But you should say that there's no edema. So important negative findings also have to be brought in, right? Huh?
In the pickle
So
probably is no edema.
yeah. Yeah, and icterus also is very important because sometimes patients with raised JVP,
Right.
severe cardiac, they have hepatomegaly, they can have liver hepatic dysfunction. We have seen bilirubins as high as 18 milligram percentage. Okay, so you have to look at icterus. So I think that is what you have put pickle. Okay, that is acceptable for me that should come before your JVP. Okay, and JVP, I think you should mention, you should say the A's are not seen. We have not seen. Obviously, you would not have seen the A wave. Did you see any A wave? Some people say you may feel the flutter, you can see the flutter waves, but better not to go into the details of that. CV wave is okay, but you have to talk about the descent also. Like why are you talking about the descent? Because what lesion are you trying to rule out with a descent? Slow by descent. What would you consider? What lesion?
Organic tricuspid.
Yeah, correct. Excellent. So that's also important finding which we have to mention. Okay. Okay. Can you proceed?
Yes, madam. And
Yeah.
more, just I want to mention, we talked more than what he wrote it. When he's describing in detail, but he wrote only the few words. Yeah. So you go to the diagnosis
yeah.
slide,
Yeah.
tell that why
Yeah.
each component you diagnosed and what findings.
Yeah.
Because many things are missed in your presentation, like a S1 variable you said. But even though it is variable, you have to say it whether it is on the whole it is loud or not. That
Correct.
is also gives an
Whether
importance.
it's generally,
No, not loud.
whether it is generally loud or soft. That is important, isn't it?
So you go to your diagnosis slide and tell the each component why you diagnose the severity like that.
Okay.
That will give the almost all of your examination findings whether you are done properly or not. Why you said it is a severe MS?
Because there is a starting from history, there is a predominant PND. Then in general examination, there is low volume pulse. The apical impulse is at normal position and is capping. It is not sustained. Then there is sign of severe PAH.
What
There
is the
are
sign? What is the
two
sign of
things,
severe PH?
two things separately you have to talk. One is why it is a mitral stenosis. Second one is what is the severity. So if you talk like that, there is no confusion. So first you say why you said the MS and then say why it is a severe MS. Or otherwise directly wanted to say what are the signs of severe MS is also is unacceptable.
Yes.
What is the direct signs for you to say it is a severe MS?
There is
Finding
severe.
is lacking. See, one finding is lacking here, which you could have heavily banged upon. That would be a dash. What is it? Despite being a mitral stenosis, you are not hearing that sound. What sound is that?
Opening snap.
Oh, you're not hearing the opening snap, right? Okay. So the opening snap, that is the most important thing which would talk about the severity of mitral stenosis. So surprisingly, the opening snap is lacking. Otherwise, you could have said, so which is the most important physical finding which would say that this is severe MS. Forget about everything else. If somebody asks you what is the most important finding, what is it? A
There
narrow?
is long.
No. A narrow A to OS interval. So that is the most important finding. Okay. So unfortunately, this patient does not have. Do you think that there is some problem? Because you got a normal S1. That's what Josla madam was asking. You said the S1 is variable. But S1 variable, whether S1 is generally loud or mostly soft. What was your impression on that?
It's soft, mostly soft.
Soft. So that means the soft S1 generally goes with the soft opening snap also. Okay. Because it indicates the pliability. The loud S1 will go with the snappy opening snap. So in this particular patient, you thought that then you should have told that, but you have not told that. Okay. So you say that this S1 was soft. That's why that important finding is. It's very important to convey that the S1 was generally soft and you did not hear an opening snap. So then what made you think so? Short of the opening snap, how will you decide the severity of mitral stenosis? One, based on, you start from symptoms. Okay.
There is PND, history of PND.
Okay. But more importantly, PND is there, I agree. Class 3 dyspnea. She's class 3 dyspnea effort now. Isn't it?
Okay, the absence of the opening snap says what? What else you wanted to add to this severe MS? Why it is absent?
Calcific, probably calcific severe.
So
Yeah,
probably
yeah.
you can say non-pliable valve.
Yes,
Calcific,
you
you
are
can't say it,
exactly.
non-pliable valve.
Exactly, Dr. Josna. I think at their level, they have to say whether it is a pliable valve or a non-pliable valve. Because
And
we
the
have gone
second
through,
is, yeah. And
we have
second
gone through days when we have just sent the patient for surgery based on only auscultatory phenomenon. Okay, just a mitral-diastolic murmur, and there was no even echo at that time, just 2D echo. Maybe there may not be there, but you get a clear, rough, rumbling murmur, loud S1, good snappy opening snap, and no MR. And the surgeons happily operates, and they come back with very good results. Even after 20-25 years, you find the valve very good. So I think that is an extremely important finding. So whether the S1 is loud, whether the opening snap is there, and what is the pliability. So the pliability is one thing which you have to sell to the surgeon. So at your level, you should say whether this is a pliable valve or not. And here it is not just pliable, it's not just severe MS. She had a procedure before, isn't it? She had a procedure. So then what would you qualify this as? Is it what is it? Is it a restenosis?
Yeah, you should say post PBMB, restenotic severe MS.
Yeah, that is very important. See, your wording is extremely. See, till that time the examiners will sleep. Okay, they'll sleep or they'll take the cashew or whatever has been served to us. But the moment you word your diagnosis, no, then they become alert. So here you have put mitral stenosis, you are cutting a very sorry figure because you have not given us the idea that she has undergone a procedure before. Isn't it? So you should say status post what?
PM.
Possibly valvuloplasty. Now coming with the, according to you,
Severe
restenosis.
restenosis.
That's the way you should tell. Okay.
Aditya sir, you want to ask anything on AS? Where he said as a mild AS.
Madam, you're asking me?
No,
Yeah.
I thought he will add something questions to the students.
Yeah. Because I think I'm having some issue with the net. My video keeps getting switched.
Oh, sorry.
No problem.
Sir, you're audible, clearly audible.
I was listening to your comments and they're perfectly valid. So you have to mention about the restenosis thing. Mild aortic stenosis. Why have you said mild aortic stenosis? Can you just clearly explain to us?
First of all, the pulse is not delayed peaking. Then apex is not sustained. There is no carotid thrill, and
what is the pointer towards aortic stenosis? ये जो सारे तुमने लिस्ट किए हैं ये तो severe aortic stenosis पे supporting features है ना?
yes.
Slow rising pulse, sustained apex. So what is the
findings that you had? What are the findings that you had to say that this is aortic stenosis?
Correct.
Yeah. What did you have? A 3/6 harsh ejection systolic. I think that's what you told. Can you go back to your findings, that finding slide? You have your finding slide.
Slide
Or
you
can just tell what was the finding on the about the aortic valve stenosis or that aortic murmur.
So you can just, I think you got disconnected.
आप अपनी slides दिखा दो मैम को एक बार.
Or you can just tell.
Yeah, just tell it.
So what is it? Was there any thrill? Was it a 3/6 murmur? What was the peaking? What do you think?
I think someone got disconnected, sir. Just a minute. I was asking to rejoin.
Anybody else is there?
Yeah, before they come, I think we have to talk about the associated lesions here, because in the presence of the MS, they should able to understand that what are the AS signs is going to happen. It is going to be masked. So to say the severity of the AS in the presence of the severe MS becomes very difficult. So that's why I wanted them to comment on that, why they said that it is a mild AS. Anyway, they came back.
Yeah.
Someone, can you show the examination slide? We were having discussion that why you called it AS, mild AS, what features you had.
Murmur?
The murmur side, the cardiovascular examination you were showing.
Yeah.
Why you were saying AS?
My goodness.
First of all, the apex is tapping in nature. It's not sustained.
That's all okay. You talk about the aortic stenosis. Grade 2/6.
There is grade 2/6 mid systolic murmur, crescendo, decrescendo.
No, you said harsh.
Early peaking.
Excuse me. You said harsh murmur. Okay. Did you
Yes,
have written harsh? What is harsh? What does harsh mean?
This is a character of AS.
What does it mean? What is the frequency? It's not a character of AS. What a character. You can have a harsh, rough and rumbling murmur for mitral stenosis. Harsh means mixed frequencies.
Mixed frequency.
Plus low frequency. That's the one which produces the harsh component. Okay. You said mid-systolic murmur, we have not said when it peaks, whether it peaks late or mid or early peaking. That you have not mentioned. So where is it peaking?
From early peaking mid systolic.
Okay. Now, whatever it is in a patient with mitral stenosis and aortic stenosis, this severe mitral stenosis, can you see that even with this finding of yours, can it be a severe AS?
Yes, ma'am. Because MS will mask the.
Jofna was asking, how does a severe MS affect the findings of severe AS? I'm telling this is severe AS. How does it affect?
MS will
anything on your history or something, from?
There is on history there is exertional angina.
Yeah, that is there. No, but the
How
other
does it-
findings, how does it
What does
affect?
it mask? पहले बता, why does it mask? Because you have to understand the physiology behind it.
Correct.
I don't
Exactly.
know.
What is happening?
Excuse me.
What happens to the left ventricle in aortic stenosis? In mitral stenosis, what happens to the left ventricle?
There will be decreased forward flow of blood
Preload.
into the
Reduce
left
preload.
ventricle.
Okay.
Preload.
Preload, and then reduced preload produces less thickening of the left ventricle. Okay. And there is a reduced preload. So what happens to the left ventricular stroke volume?
It will decrease.
It will be reduced. So therefore, what happens to the aortic gradient? Even though it is severe AS, what can happen? The gradient may be
It will be reduced.
severely
It may be reduced.
underestimated. See, it can be severely underestimated. We have had patients after BMV developing severe pulmonary edema on the table because the aortic stenosis was underestimated. You understand? So it can be even a very faint murmur or totally even absent murmur or just, just like this non-discrepant murmur. Okay. You can totally miss. Okay. That is the thing. And you said about S4. S4 may be totally absent in a mitral stenosis because of the MS, there is no S4. There's no forcible apical impulse because there is no left ventricular thickening. So there is a lot of combinations and combination which is happening in this kind of lesion. So the mitral stenosis affects all the findings of aortic stenosis. All the findings get muted or reduced. Okay. And the proximal lesion dominates. Okay. And you can seriously miss an aortic stenosis. So that's important. So even with this, you can have a severe A. That's my point. Okay.
So, ma'am mentioned a very important point. So, I think, ma'am, with paucity of time, we can go ahead with ECG,
Yeah, please,
X-ray,
please.
and
Yeah, please. Yeah.
Can you show the ECG, X-ray?
Yeah.
X-ray, this is X-ray PA view. With CT ratio of 0.6 with RV type apex. If there is a straightening of the left heart border, as there is underfilling of LV with enlargement of left atrial appendage, with dilated main pulmonary artery with inconspicuous aorta. There is also left atrial enlargement as there is double contour sign, as well as there is a widening of the carinal angle. RA right atrial also enlargement of the right atria as it involving the more than 3 intercostal space. There is a dilatation of the main pulmonary artery.
You have a pointer. Can you see the structures on the left heart body? What are the structures that you're seeing? Can you show with the pointer? No. Okay. So from above down, what are you seeing? Left heart border. It's difficult. You just tell what are the findings.
ऊपर से cranial to caudal क्या structure है?
Left heart.
Aortic knuckle followed by dilated pulmonary artery, followed by LA appendage.
Okay, very good. So LA appendage, and then comes the probably the
apex is RV type. Yes, sir.
Left ventricle. Okay. And what about the pulmonary vascularity? Pulmonary, what are you seeing?
Pulmonary vascularity is increased, ma'am.
No, you have the prominent or dilated MPA. RPA is not very much dilated, but there is pulmonary venous hypertension. You'll agree about pulmonary venous hypertension?
Yes, sir.
What else will you look for? What other lines will you look for?
Curly B lines.
Are you seeing any curly B line? Probably no.
There are some curly B lines.
Maybe there are a couple of curly B lines in the mid. Here you can see some curly B line, one or two. What are the other lines that you would see? You're seeing
curly C lines.
Curly C and curly A lines, isn't it? So you're seeing the curly A lines, you can see the vertical lines which are going up towards the hilum. And there is increase in the pulmonary venous size, the pulmonary veins is also increased, and you can trace it up to the first intercostal space. So there is pulmonary venous hypertension as evidenced by left atrial enlargement pulmonary venous hypertension, and also you see some. What is the other thing in the bronchus that you would look for in pulmonary venous hypertension?
Peribronchial cuffing.
Yes, exactly. Very good. Okay. So there is some peribronchial cuffing. You see each bronchi, you can see the thickening of the wall of the bronchus. Okay.
I wanted to add one point to this pulmonary arterial hypertension. So first comment you made it is increased vascularity. Actually, pulmonary arterial hypertension, once it starts setting in, it causes the peripheral pruning. So you have to see that is increased vascularity is confined to the center into the main pulmonary arteries or going to the more peripherally. That is most important. Clinically, you suspect the severe PAH. So you don't expect to the vascularity to be then increased. So what you are seeing is the more capillization and PVH is more and the patient has the history of the PND. So whether you see an X-ray or not, in the clinical diagnosis, you have to mention the severe PH, which you have done it, which is absolutely correct.
The mustache line also, which would indicate PVH. And what is the condition in mitral stenosis where the vascularity can increase? You have a torrential vascular increase in vascularity. Associated condition. Now you'll find the markings. Associated aortic atrial septal defect. Okay. There is one condition where there will be huge cardiomegaly, plus you'll find increased multiple end-on views, and you can trace the pulmonary vessels up to the periphery. Okay, that is just yeah. I think X-ray is done well. Okay.
Okay.
ECG. ECG. You have shown the ECG.
Yeah,
Just go ECG and echo.
Yeah.
Parallel ECG showing atrial fibrillation with controlled ventricular rate with a heart rate of 80 per minute with frontal QRS axis of with no evidence of any chamber enlargement.
Yeah, what is the QRS axis?
Axis around 60 degree, man.
AVL is negative, so it will be around 75. Okay. Yes. Any atrial enlargement? You can't say because of atrial fibrillation. But sometimes right atrial enlargement, you may be able to say from a negative, you can get a QR in V1. Okay. Is there any evidence of RVH, suprasystemic pressures? No. But I've seen a dominant R wave, isn't it? Or a QR in V1. So that's very important to indicate RV stress. Any LV forces? You're talking about mitral stenosis. Aortic.
You are not surprised that RVH is so clinically grossly the seen and you are not able to see any RVH on ECG? Are you not surprised?
Yes, sir.
So what can cancel RV forces? I gave you the answer.
It may be possible in your case.
Increase LV forces.
Okay, if there is significant LVH, the RV forces can be cancelled. Okay, that is one thing. Okay.
Can we have the echo?
Yeah.
This is the parasternal long axis view showing thickened looming mitral valve with the thickened aortic valve and left atrial enlargement. This is the 4-chamber view. There is no MR.
Maybe there's
Showing
maybe there's a
gradient across the. There is mild AR. Tricuspid thick calcified aortic valve.
Trying to look at the appendage.
Velocity of 4 and peak gradient of 70.
What?
Aortic velocity of 4 and
Do you
1 peak
think it is
gradient.
an aortic velocity because the line seems to be going through the mitral valve, isn't it? Can it be an MR? Was there any MR earlier in that?
MR is not there. There is no MR.
The aorta is not fully opened up. So
Yes,
we open up there is some MR.
There is some MR here, na, because जो मैडम point out कर रही है कहाँ पे तुम्हारा CW का signal आया ना, the aorta was not very well profiled.
So the aorta is not.
Otherwise, by seeing the spectrum, can you say that is A spectrum or MR spectrum?
Yes.
envelope से spectral envelope से बता सकते हो सुमन?
MR will be wider and is mostly tongue shaped.
So almost tongue.
It is the first component is the
Envelope.
pansystolic, and it starts immediately along with an aortic valve opening. The darker line in the beginning of the dissection, you are able to see it now. So that is an aortic valve representation on the Doppler. So that will be the wider. That will starts along with that, and throughout the systole it will be the present. And the, as you said, is the tongue shaped. Here there is a rapid rise of the pressure in the aortic stenosis, mainly depends upon the severity of the stenosis. So these are the distinguished by seeing the spectrum. Also, you can say there is an MR spectrum or AS spectrum.
Yeah. And on echo, the MR was quite not very severe. It's probably mild MR, so it not produce such dense echoes. Likely to be aortic stenosis.
And you got such a high gradient. So what madam is saying is more relevant now than saying clinically as a mild AS.
Yeah, I think the echo has shown what we were discussing also, that aortic stenosis severity can be decreased with presence of severe mitral stenosis. So, ma'am, if you allow, due to paucity of time, we have already crossed 15 minutes. We can
Please. Yeah,
go ahead with the talk. Yeah, go ahead with the talk. In the meantime, we will just answer the chat questions. And in the end, we can have the summary. So I would request Kapoor sir to kindly share the slides and whatever the point discussed. And we can have more insights how to approach a case of stenotic lesion. Sir, over to you.
Yeah, my screen is visible.
Yes, sir, it's visible.
Yes.
So,
Indeed.
madam, thank you. It's a privilege to be on the same forum as you. So I'll try to go ahead. Yeah. So mitral stenosis for all the students, before we come to severe MS, in today's world, the examiners may also ask you what is the stage. So at risk for MS is mild doming, no transmitral gradient. You have to understand asymptomatic progressive MS is valve area more than 1.5 and PA pressures are normal at rest. Stage C and D are valve areas less than 1.5, PA pressures are high. And stage C is, of course, asymptomatic severe, and stage D is symptomatic severe. Some classifications also include this one more category in this, very severe MS, that is valve area less than 1. So you have to be aware of this. So paradoxically, severe symptoms, even when the MS is theoretically mild, it can happen in infections, anemia, rapid arrhythmias, any decompensation, pregnancy, thyrotoxicosis. So just to give you that thing. And before we go actually to this, as madam also said, and Dr. Rupali is also aware, you should also be aware of some very, very important historical articles for mitral stenosis and aortic stenosis. I'll try to put them up as well. So pointers to severe MS by history. मैडम ने वो बताया ही था अभी केस में PND orthopnea. These are signs of severe pulmonary venous hypertension. So there is no question if the guy has PND orthopnea, mitral valve disease is likely to be severe. And Hurst's book clearly says with severe MS, elevated pulmonary vascular resistance in the end stage, fatigue may set in rather than dyspnea. This also madam pointed out that right heart failure or severe PH may present with fatigue rather than PND orthopnea. Angina. Again, I'm so glad that madam pointed this out. And again, all of you who are appearing for exam should be aware that this was first brought out by Paul Wood's paper, Appreciation of Mitral Stenosis. So go through this paper, and he categorically said that angina disappeared in all those who had a successful valvotomy. So don't ignore angina in your history. Madam also said about hoarseness briefly, that when the LA enlarges, so Ortner syndrome, we all know that, recurrent left laryngeal nerve palsy. So PND, orthopnea, angina, hoarseness. These are important symptoms of severe valve disease. Briefly, again, cardiovocal or the Ortner syndrome, be aware that valvular lesions are an important cause. Shunt lesions are an important cause. Madam ने बताया था वो कि when the atria dilates, usually in shunt lesions, aneurysms, myxomas, and any cause of severe pulmonary artery hypertension. These are all causes of Ortner's or cardiovocal syndrome. Then for mitral stenosis, the third thing you will come to is, the second thing is general physical examination. So mitral facies, again, this is a historical thing now. We never see this, but again, be aware that bilateral malar flush, hyperpigmentation is a sign of severe mitral stenosis with reduced cardiac output leading to vasoconstriction. And this is associated with a low volume pulse. So not many books say that low volume pulse is a sign of severe MS, but severe MS mein ho jata hai low volume pulse, but by and large, it is not considered as a sign of severe MS. Only when the cardiac output reduces, pulse will be low volume. Third, pay attention to JVP. So I brought in some visuals for you. If you see this is a prominent A wave, severe pulmonary artery hypertension, and as opposed to prominent C wave, which is TR. So examiners will sometimes again ask you कि A और V wave में फर्क कैसे करते हैं. So we all know timing pre-systolic is A, V is end systolic, but again we were all taught, and it's a great clinical sign, that duration of A wave is just like a flicker. It just flickers and goes away, while V wave is more sustained. So remember this point: flicker, sustained, A and V. Signs of pulmonary artery hypertension. So I'll tell you 10 commandments for mitral stenosis. We are on the fourth one. So signs of PH agar aa rahe hain, which are palpatory signs: parasternal heave, palpable P2. Very important historical paper, left parasternal impulse, described by this group in 1964. And interestingly, they use this device, impulse cardiogram. So kai baar examiners spotters mein bhi le aate hain. So this was an impulse cardiogram, and they used it to document the movement of the apex. Normal mein, it is, we know, gentle outward movement followed by a late retraction, and mitral stenosis, sustained parasternal heave. So this is what was documented nearly 60 years ago, left parasternal impulse. Percuss the second left intercostal space, always, to see if the pulmonary artery space is dull or resonant, to understand whether the PA is dilated or not. Auscultation, remember, loudness of S1 has no correlation with the severity of MS. It only correlates with the pliability. Severe MS, we discussed in the previous case, long pan-diastolic rumble. Milder MS, short early diastolic rumble. So I don't know whether this audio will play. It's a great audio from Jules Constant's audio, book on murmurs. So this is a prominent MS murmur. Just listen to it. But anyway, so this is described as a growl and a bark. So you can see this audio thing on the net also, the Jules Constant audio book, or listen to this rumble. So long pan-diastolic rumble is a sign of severe MS. Again, be aware of low gradient severe MS. This is just like low gradient aortic stenosis. This is a newly described entity. Go through this paper published in Journal of American Heart Association 2019, that sometimes even with severe MS, the gradient may be less because of a low stroke volume index. So you have a high gradient MS and a low flow, low gradient MS. That is a mean gradient less than 10 with a low stroke volume, and especially common in people with low cardiac output, atrial fibrillation, older people. So how to bring out the murmur? Make the murmur louder in a patient of MS by going to the left lateral decubitus, end expiration, mild exercise, hand grip. So do all these maneuvers. Again, Hurst's book clearly says failure to examine the patient in the left lateral decubitus is accounting for most of the misdiagnosis of symptomatic MS. So whenever you are auscultating for MS, always the patient go to left lateral as well. The seventh important sign, again, we all know, A2OS interval, nearly 30 to 150 milliseconds following the A2. S3, remember, is a sound which is later in the diastole as compared to the opening snap. So early diastolic is opening snap, nearly 40 to 120 millisecond. Mid diastolic is tumor plop. Tumor plop occurs earlier than S3 and later than opening snap. And again, pericardial knock is again early to mid diastolic. So the earliest amongst all these sounds is the opening snap. Don't get confused by this. Remember these intervals. And we all say that agar A2OS interval is more than 120, then it is milder MS, while with severe MS, the intervals come down to 40 to 60 milliseconds. Of course, difficult to discern this. This is just a theoretical question. You should be aware of this. And I don't know again whether this will be audible. audio library. Other signs of pulmonary artery hypertension, look for pansystolic murmur of TR. I mentioned already RV heave, pulsatile liver, and a right ventricular S4. Now, who is this guy? This is Graham Steele. And he said, my rule in clinical practice is never to trust one physical sign. So always, as Rupali was also pointing out, go and look at multiple clinical signs to corroborate all your findings. Just don't go by one sign alone. And Graham Steele, you will be surprised to know that the Graham Steele murmur of PR was actually described first in mitral stenosis. So he actually documented कि जो end diastolic murmur, early diastolic murmur आ रहा है, that is due to severe pulmonary artery hypertension and PR. Not many people believed him, but anyway, this is a point of historical interest. So we say that अगर कोई EDM आ रहा है, so it is usually due to AR, but look for it whether the murmur is starting with A2 or P2. So these are all the clinical signs. ECG signs of severity we discussed: left atrial overload, right axis, right ventricular hypertrophy. Remember, AF is not a sign of severity. Usually AF occurs in severe MS, but the reverse is not true कि अगर AF है तो जरूरी नहीं है कि MS severe ही हो. So again, left atrial, biatrial overload with RVH strain. Remember, in atrial fibrillation, you might get fooled because enlargement atria का दिखेगा नहीं. Madam pointed out that you might get a QR in V1, pointing out to a right atrial enlargement. So this is atrial fibrillation. You're getting some R waves in V1, not a QR suggesting RVH and a right axis deviation. So atrial fibrillation with right axis deviation and RVH, suspect mitral valve disease. X-ray signs we have discussed: left atrium enlargement. Remember, the LA on the X-ray very rarely enlarges inferiorly. It might go to the right, might go to the above to distend the carinal angle, might go posteriorly and indent the esophagus on the barium swallow. Rarely goes inferiorly. So widening of carina, elevation of left bronchus, straightening of the left border. Important historical things: double atrial shadow. So grade 1 is just a double contour. Grade 2 is the LA touches the right atrial border, and grade 3 is LA overshoots the right cardiac border. So extreme examples of mild or extreme LA enlargement. Assessing pulmonary venous hypertension, Madam discussed it. Remember that the flow at the lung base is more. Upper lobe vessels are less than the accompanying bronchus. Ratio is 0.85. At hilum, they are equal. And in the lower lobes, they are larger. So remember this gradation of vessel to bronchus. Upper lobes में less, hilum पे approximately equal, lower lobe में they are larger. With redistribution, the antler sign, we say increase vessel to bronchus ratio in the upper and middle lobe. Madam pointed out that on the X-ray. So grade 0 we know, grade 1 is the antler sign. I'll just show you in X-ray. So clearly the antler sign here, and I magnified this. Increased vessel to bronchus ratio in the middle lobes. So this is a very, very important sign. And grade 2, I think Amit also answered, peribronchial cuffing. So clearly see the peribronchial cuffing here. And grade 3 is the alveolar edema or pulmonary edema. Curly lines, again, just to revise, curly A are running from periphery to the central hilum. Curly B, horizontal lines at the base. They are the ones which are highly specific for PVH. Curly A is not. Curly B is more specific for PVH. Curly C is at the lung base. They are basically curly B lines end on. And there is also a curly D, which is same as curly B, but seen on the lateral view. So reticular retrosternal opacities. So curly A, B, C, D. So this is for mitral stenosis. Again, the residents can take a picture of this. These are very, very important articles. Bland and Jones, natural history, Selzer and Cohn's natural history, and of course, Rappaport series. So again, for mitral, Rupali, I'll just quickly run through the aortic as well, if you permit me about 5-7 more minutes.
Yes, sir. Sure, sir.
So again, these are the normal values. Moderate to severe aortic stenosis is less than 1 or 1.5. The peak velocity is more than 4 in severe, and mean gradient is more than 40. Not spend too much time on it. Pointers to severe AS by history. So we all know this: angina, syncope, heart failure. Importantly, Hurst's book clearly says symptoms are unusual unless AS is severe. So यदि AS severe है, symptoms होंगे ही होंगे. Angina, syncope, or heart failure. So again, coming to the general physical examination, this is the first. Again, aortic also tried to bring in 10 points so that there is a uniformity to the discussion. Pulse, slow rising pulse, low amplitude parvus and a late peak tardus. So late peak isliye hota hai because there is a prolonged ejection, there is obstruction to the flow. This is a good algorithm which we used to learn when we were in the DM's training as well. Normally the carotid pulse occurs closer to S1. So you see over here, the peak is closer to S1. In anacrotic, because of the delay, it is closer to S2. So this is again a good cartoon to remember. And sometimes, of course, we all know that in elderly, this sign may be absent. But again, by and large, anacrotic or a slow rising pulse tells you that the aortic stenosis is severe. Out of the two components, tardus is the better discriminator, not parvus, right? A low volume pulse can even occur with milder aortic stenosis. Reduced ejection fraction, hypovolemia, and mitral stenosis. So these are the overriders that a low volume pulse can even occur with milder AS. So that is why tardus is a better discriminator than parvus. The third sign, of course, we know systolic decapitation. Not many people believe that, but for advanced aortic stenosis, the pulse pressure narrows. JVP, not much. If the JVP is elevated, shows some A or B waves, then you go back and suspect mitral valve disease. JVP will not get elevated in pure aortic stenosis until and unless there is associated mitral valve disease or associated severe LV dysfunction. Palpation, again, very important for aortic stenosis, a sustained apex, heaving, forceful, sustained, undisplaced. It is usually not down and out until and unless there is LV dysfunction. Apicocarotid delay on palpation, a palpable LVS4. Systolic thrill, not many people believe is a sign of severe aortic stenosis. So, as mentioned in the books also, it is a relatively, carotid shudder is a relatively specific but insensitive sign of aortic valve disease. So I would say the first three things: sustained apex, apicocarotid delay, and a palpable LVS4. So again, this important article, Archives of Internal Medicine 1952, these are the guys who first described the apicocarotid delay and said that it is nearly 100% specific with a positive predictive accuracy of 100% for severe aortic stenosis. Auscultation, again, the loudness of the murmur has no correlation with the severity of AS. S1 is usually normal. You might get an aortic ejection click if the valve is pliable. These are the four important things in auscultation which you should remember. For aortic stenosis, the splitting of the S2, the intensity of the A2, length and peaking of the murmur, which Madam discussed, and of course the presence of an S4. So S2 splitting, this is the normal split. Reverse split, which happens in severe AS. I just brought in this figure as well, wide split. So अगर आप देखोगे reverse split में भी expiratory splitting है, wide split में भी expiratory splitting है. So what is the difference? Sometimes candidates get confused. The main clincher is the A2P2 interval during inspiration. अगर आप reverse split में देखोगे, the A2P2 interval has closed. In wide split, it is still there. So that is the main clincher. Again, for paradoxical splitting, try to read this article. It's a great article, British Heart Journal 1956, Ian Gray's paper, which said that closing of the split second heart sound in inspiration is a very, very important thing. And he says that normal splitting of the sound was never seen when the aortic stenosis was severe. So whenever you're making a severe aortic stenosis, the splitting either has to be it has to be a closed split or it has to be a paradoxical split. Normal splitting can not happen by and large with severe AS. Importantly, examiners ask you causes of reverse splitting. So we all know aortic stenosis. Don't forget left bundle branch block or RV pacing, ADA, WPW. Out of these, the most prolonged reverse splitting occurs with left bundle branch block, does not occur with aortic stenosis. Intensity of A2, of course, more severe the AS, the more calcified the valve, the A2 becomes absent. Length of the murmur, we discussed, the longer the murmurs, more severe is the aortic stenosis. Madam discussed about the character of the murmur. And historically, what people described it like a person clearing their throat. So put the palm on the diaphragm of the stent and try to scratch it. This was all, medical school we learned. But longer the murmur, more severe is the AS. Late peaking of the murmur, of course. So this is a new concept which has come in, the time to peak velocity on the echo. Examiners may ask you. So this is a surrogate for a late peaking murmur. Time to peak velocity. So you measure from the onset of the spectral onset of the Q wave to the peak of the spectral envelope. And what people have said, if it is more than 95 or 100 millisecond, the aortic stenosis is likely to be severe. So it's just a surrogate for a late peaking murmur. I'll just run through this. LVS4. Again, S4, if you are hearing, the gradient has to be more than 60 to 70. Remember, you will never hear S3 in aortic stenosis until and unless complicated by severe LV dysfunction. ECG, of course, left ventricular hypertrophy with strain, you will find in severe AS, but remember, ECG in severe AS, even in severe AS, LVH may not sometimes be very evident on ECG because ECG is not very specific or accurate to pick up LVH. अगर है तो LVH होगा, but जरूरी नहीं है कि aortic stenosis में LVH मिले. This is an important ECG. So atrial fibrillation, but LV forces are there. So if you see atrial fibrillation with LV forces, so you should suspect अगर aortic stenosis के patient में AF मिल रहा है या right axis deviation मिल रहा है, so then you suspect mitral valve disease. X-ray signs of aortic stenosis, of course, you don't find any cardiomegaly in pure AS. You might find the ascending aorta to be dilated. Cardiomegaly or PVH only when the patient goes into failure. Calcification of the aortic valve might be seen on the lateral view, but it has no correlation with severity. It is only age dependent. So these are the signs on, X-ray. So for aortic stenosis, also remember to go through these natural history articles. Very, very important. So I'll finish off severe MS. Important signs: facies, pulse is plus minus according to me. JVP. Signs of pulmonary artery hypertension, whether auscultable or palpable, a long pan-diastolic murmur, the A2-OS gap, and of course the ECG and the X-ray. Severe AS, pulse, epicocarotid delay, sustained apex, LVS4, split of the S2, long late peaking murmur, and ECG and X-ray. So lastly, I'll conclude, Madam touched upon this. The MS AS dono hai. So MS will mask the aortic stenosis. Madam told the reason why it happens, so I'll not spend time on that. Again, go through these 3-4 articles to understand how MS and AS interplay with each other. This is the original article published by Zitnik's group in American Heart Journal. This is a recent paper, and this is even more recent, 2021. So I'll conclude by, this is the last slide. Suspect mitral valve disease in AS if the patient has got AF, if the patient has got JVP signs, if the patient has got signs of pulmonary artery hypertension, a long rumble. A2-OS may not be accurate because agar aap realize karo, aortic stenosis mein the split becomes paradoxical. So A2 moves later. So A2-OS may not be very accurate. So you have to rely sometimes on the ECG. Yadi ECG mein atrial fibrillation aa raha hai, RVH aa raha hai, right axis aa raha hai, you might suspect mitral valve disease. If the X-ray shows pulmonary venous hypertension or LA enlargement, you'll again suspect mitral valve disease. Similarly, for aortic valve disease, suspect aortic disease in mitral stenosis if the pulse is slow rising, if the apex is sustained, if you're getting LVS4. Madam pointed out in pure MS, LVS4 nahi milega. So yadi S4 mil raha hai, either palpable or audible, you have to suspect aortic valve disease. S2 is paradoxical or single. A late peaking murmur. ECG shows LVH and X-ray shows prominent ascending aorta. So these are the ways how you can diagnose severe MS, severe AS, or combined MS or AS. Thank you.
Sir, really
Thank you, sir.
excellent.
It was,
Excellent.
yeah, ma'am, sorry.
And I think the studies what you are quoted has to be known to the each and every person. So I request you to give your PPT, sir, so that we can post in our the website and as well as to the students. So already they started asking, what are the studies? Please repeat the MS studies. Everyone remembers the Rappaport study only. So I think please your PPT is an excellent and really informative to all of us also. Thank you.
And this is all credit to Rupali because she motivated me to make it.
No, sir, you are being very humble, but I think it was really a pleasure. And every time, whenever we listen you, I learn new things from you. It's many pearls of wisdom and many new articles. And I think all the points which you discussed, it was really pleasure. I made notes also, frankly speaking. I was just writing down what you all did. So it was really a pleasure to
And
hear from you.
Smita madam, within a short time, she added so many important clinical signs. I don't know that you can incorporate so many signs within such a short time. Really, thanks to Sunita madam.
Great case
Sunita madam,
discussion. Very good discussion.
So I think Dr. Somang and Dr. Amit did a wonderful job by that case presentation, and most of the points which were asked by examiners, it was very well addressed. And the points which were made by Jyotsna madam and Sunita madam, like LVS 4 and other points, they were really helpful for the examination part. And icing of the cake was Kapoor sir's lecture, in which all the important studies or what are the pointers for going for a combined lesions, which helped us. So any final comments, Jyotsna madam and Sunita madam, and then Kapoor sir, we can conclude then.
Yes,
Jyotsna madam.
thank you. Really, it is educative to me also. I'm very happy once you prepare the questionnaire separately so that we can give them all answer to them, because we are lacking of the time of to answer the what is in the chat box. So definitely we will try to help to the students subsequently.
Yes, but most of the questions we have answered. I think Anita Saxena madam was there in the chat box, so she mentioned many beautiful comments and the pointers for the examination. So we didn't respond to that, frankly speaking. So, but what are the chat question? And for the one of the person has mentioned.
We can add it
Yeah,
in
so
the
for
final
the
moment.
yes, ma'am. We will add all the final comments in which Anita madam asked in the comments. And the recording we will be available on our Wincars website in a time of maybe 5 to 7 days. We will edit it and we will just upload the recording. So all the residents can go through that recording from our Wincars website. Sunita madam, if you're there, can I have few comments from you? Okay. I think we have lost. She's there, but she's up. Kapoor sir, it's your first association in Wincars, so just comments from your side also.
It was an absolute pleasure being here. So thank you for inviting me, and I would put in my request to be associated with you once again, more and more lectures. So I would want to be part of this. It's a great opportunity, and thank you so much.
Usha, are you there?
Yeah, hi Rupali. I think it was a absolutely brilliant session, especially Kapoor sir's talk. Are we going to announce the next agenda also right now?
We are at the process. Maybe another week time we can just announce.
Yeah, but it would be there next month. And
yeah, every fourth Thursday. Yeah.
Every fourth Thursday. Yeah.
So in the end, we can conclude the session, and I thanks all the speakers and the presenters for joining, and especially the attendees. There were more than 100 attendees who joined this session and having a continuous interaction. And the Medcami team and the Sun Farmer people for helping us organizing this webinar. So I conclude the session, and maybe next fourth Thursday, we can just meet again. Thank you. Thank you, ma'am. Thank you, sir.
Thank you. Thank you.